Okay, are we ready to go live? Okay, welcome to the May 15th, 2020 Third Friday Case Conference, the treatment of substance use disorders and addiction during COVID-19. Next slide, please. This is a joint collaboration between the American College of Medical Toxicology and the American Society of Addiction Medicine. We're joining together this moderated panel discussion of interactive case discussion. I'm Tim Wiegand, the Director of Toxicology from the University of Rochester, and we have a distinguished panel of experts. Next slide. Joining us today, Dr. Gloria Bashevitz, who's the Director of Addiction Psychiatry, Strong Recovery Addiction Psychiatry, and the Medical Director of the Adult Ambulatory Program for Strong Health, and Professor of Clinical Psychiatry at Rochester Medical Center. Dr. Ken Connor is the Co-Director at the Center for the Suicide and Prevention of Suicide, a clinical psychologist and Professor of Emergency Medicine and Psychiatry, also at the University of Rochester Medical Center. And Dr. Robert Horowitz, the Chief Division of Palliative Care, the Georgia and Thomas Gosnell Distinguished Professor in Palliative Care at the University of Rochester Medical Center, and Dr. Ross Sullivan, Director of Medical Toxicology, Upstate University, and Medical Director, Helio Health, and Director of the Opioid Bridge Clinic, Syracuse, New York. And Dr. Ingrid Vikas, the Clinical Associate Professor in the Department of Emergency Medicine and Internal Medicine, Physiology, and Pharmacology, Cummings School of Medicine, University of Calgary, Alberta, Canada. And Dr. Melissa Weimer, Medical Director, Yale Addiction Medicine Consult Service, Assistant Professor, Yale School of Medicine, and on the Board of Directors for the American Society of Addiction Medicine. Next slide. CME accreditation is available for this course. Participating in it, you can receive a maximum of 1 AMA Category 1 credits on completion of the survey at the end of the event. Next slide. None of our speakers have any conflicts of interest to disclose related to this event. Next slide. And we're going to jump right in with the case, and starting with case 1, involves a 58-year-old male with an opioid use disorder who was treated with 8 and 2 milligrams of buprenorphine naloxone, taking 2 films a day. He's diagnosed with nephrolithiasis after an emergency trip to the hospital. Next slide. A little bit more of our patient's history. He has a long history of opioid, stimulant, and alcohol use disorder. He's been a client in an outpatient treatment program for just under 2 years, where he has monthly visits with a counselor and monthly visits with an ex-waiver primary care provider who's worked in the outpatient treatment program for years with him since he was transferred from a local detox on a bridge prescription. He's prescribed 2 of the 8/2 milligram films of buprenorphine naloxone, which he'd initiated while in the detox just under 2 years prior, which he'd entered to stop using Vicodins, and that's basically it, is what he said. But prior to entering the detox, he'd had several unsuccessful attempts to stop using what he reported as primarily prescription opioids, although the urine drug testing company his current treatment program is utilizing is one that a prior treatment program used, and he has numerous fentanyl, monoacetylmorphine, morphine, codeine, cocaine analytes detected in the 1 to 2 years prior before entering his current program while he was in the other program. About 6 to 7 years earlier, he had struggled with alcohol, but stopped after a 5th DWI and a period of incarceration. Upon release, however, he starts using opiates, and when he started using opiates, he struggled until the detox initiated buprenorphine in 2018. Next slide. Primarily, past medical history is generally healthy other than some chronic back pain and his substance use disorder. His social history is that he had worked as a car technician and a mechanic prior to his last DWI, and at the time he owned a snow plowing business and repair shop before quitting. He still has some business in reselling parts and some of the plowing equipment, but it's not full-time. He's divorced, has 1 son and a 4-year-old granddaughter that live in the area. He smokes cigarettes, about a pack a day. He lives in a small apartment by himself, and his medications include the buprenorphine naloxone, 2 of the 8s a day. Clonidine, he takes 0.1 3 times a day, just as needed for anxiety, adjunctive to the buprenorphine. And he has diphenhydramine, 50 milligrams. He takes up to 4 times a day for allergies, no other medications. Next slide. The patient was very anxious initially about social distancing and home isolation as the COVID-19 pandemic and state of emergency was announced, but he maintained contact with his providers via telehealth, audio and video, and a phone combination. And about 2 weeks after his last telehealth encounter, he gets monthly prescriptions, but he checks in about bi-weekly. The pharmacy calls the program asking for instructions on what to do with the morphine that he's trying to fill. He apparently has 2 prescriptions he's at the pharmacy picking up. One is his regular buprenorphine naloxone, which is 8/2 milligrams, 60 of them is due. And the other is morphine 15 milligrams, immediate release, number 20. The patient hasn't called his provider or counselor. It's late in the afternoon, and the program closes at 5. And this is prior to any of the information we knew about the nephrolithiasis. And my question to our panelists, what do you say to the pharmacist? Have you been presented with something like this when patients are on medication for opioid use disorder and a pharmacy calls asking for clarification? Dr. Bishevitz, can you give us some insight, or has this occurred in your practice?
Yes, that certainly has occurred in my practice, and I guess what I would do is try and look at the chart and see if I could get any records from other institutions and try and figure out what's going on from there.
And Dr. Weimer, if has this happened to you, what would your response to the pharmacist be? It's about 4 o'clock, 4:30, and the program closes at 5, and the patient's voicemail is the only thing that can be reached. He's apparently at the pharmacy.
I guess I'm presuming that perhaps this is for the treatment of his nephrolithiasis, perhaps. So I would, if I thought that the patient was reliably staying on the prescription of buprenorphine, I would feel comfortable treating for acute pain on top of the buprenorphine. Sorry, there's some feedback there. Otherwise, I would really want to try and get some more information from the patient to know what's going on. And then, just to step back and say, if I were to utilize a medicine to treat acute pain on top of a patient who's on buprenorphine, I would typically choose a different type of agent, such as hydromorphone, which has more competitive binding at the opioid receptor when patients are prescribed buprenorphine.
Yeah, thank you. Dr. Horowitz, in your practice in pain and palliative care, I'm sure this has arisen. What would you do in this situation? And this is before the case summary, not knowing quite that this gentleman actually has the nephrolithiasis, but trying to sort this out late in the day.
Right. Yeah, I need more information from him. So my contact with my patient is no other opioids than what I'm prescribing unless you and I talk about it first. So this is coming out of the blue. I'm surprised, depending on my relationship with him, and I'll assume I have a good one. We've talked about this before, so I expect to speak to him. If I'm in touch with a pharmacist, I've often had the pharmacist put the patient on the phone if the patient is there, so I can get a little bit to the bottom of it. So everything depends on who this patient is in terms of his medical history, his well-being, his recovery, his risks, our relationship. So much more to figure out. But no, I'm not going to say go for it until I've had a good conversation with my patient.
Very good. Okay, well, let's get a little more information. Let's advance slide and we'll find out a little bit more about the situation. And the treatment providers ask the pharmacist to hold on to, but to release the buprenorphine prescription, and also request the patient be asked to call and discuss the new prescription as he is apparently there and dispensing the buprenorphine, which he does. Instead of calling the program, he calls his counselor, who notifies his provider, who calls him back, so phone tag triage. And the patient describes that he'd had severe flank pain for about 1 to 2 days. He was very concerned about going to the emergency department due to COVID, and this is mid-April in upstate New York. but he finally had to call an ambulance because the pain was so bad. He had not reached out to the treatment program during this. Over the last 18 months, he's done remarkably well. He has regular urine screens, and they're consistently free of other substances and with good metabolite, buprenorphine metabolite profile levels, indicating that he's taking the medication, and there really hadn't been any concerns. But he says the pain was so bad he had to call an ambulance. And in the ED, he's diagnosed with nephrolithiasis and ultimately is found to have a single 3x3 millimeter stone that's at the edge of the bladder. Well, in the emergency department, he was first given morphine, he says, which didn't do anything because of my Suboxones. And then they gave me Tora or Ketora something, and then Dilaudid, and that really helped. And he reports that after a few hours, the pain dissipated and he was sent home. And it's been about 24 hours since he was in the ED. He wants to have the morphine on hand, just in case. I don't want to go back to the emergency department again. He basically says, I'm keeping myself in my house and I'm worried about getting COVID. I was terrified in the ED. I just want the morphine on hand. Next slide. There's no history of kidney stones. There was only the single stone visualized on imaging in the ED. In addition to the morphine, he'd been prescribed the tamsulicin and ibuprofen, which he said he'd not needed to take in the 24 hours after. He says he would prefer to pick up the morphine to have on hand just in case. Next slide. So during a lengthy phone conversation, the patient and medical director discussed the risks and benefits of having a morphine prescription available at home, as well as the likelihood of having more pain given where the stone was, and he'd been doing well for 24 hours. And ultimately, he conceded to a call if he starts to have more pain. He has a follow-up with a urologist in a few days. He's been taking the tamsulicin and drinking a lot of water. So I'm wondering, hearing this, would others have done anything different? Can you comment a little bit on the concern about going into the emergency department during the COVID pandemic? Have others seen this? Ingrid, Dr. Vikas.
Can you hear me?
Yes.
Yeah. So I guess there are a couple of issues here. One is the home management of nephrolithiasis after being sent out from the emergency department. And certainly even for acute management in the emergency department, opiates are not considered to be the first choice that NSAIDs are, and they seem to work really well, and that seems to be the better guideline rather than, so I was surprised that he was sent home with morphine, and the ibuprofen would be a better choice for him, or perhaps another NSAID that he would require a prescription for. The issue, and so there are other ways I think to be able to deal with this pain, particularly because he's on buprenorphine, but to address the issue of his anxiety about going into the emergency department, I'm not sure what the situation is in many of your communities, but in our community, unlike New York City and places in Europe and Italy, our emergency departments are not overrun with COVID patients. In fact, the volumes are down by 30 to 40%. Emergency physicians have had their shifts canceled because they just don't need that many of them on. So and the concern, I think, of patients staying home with other medical problems other than COVID, and coming in late with their MIs, coming in late with other, neurologic problems. And so I would look at reassuring him, again, depending on what's going on in your community, but in our community, I would reassure him that the likelihood of his getting COVID in the emergency department is far lower than getting it grocery shopping or somewhere else where there are larger numbers of people accumulating. So I would reassure him that way. And I think the third thing is that we should probably look at maximizing his buprenorphine treatment. Buprenorphine is good pain management, maybe looking at splitting his dose further or increasing his buprenorphine dose is what I would consider reviewing with him rather than moving to an opiate like morphine.
Yeah, those are great comments. It's very interesting. Just earlier today I was speaking with a patient whose significant other apparently has a very red and swollen foot, and she's worried it's either cellulitis or a very severe gout flare, and it's getting worse, and he's not willing to go into the ED or to an urgent care because he's concerned about, getting coronavirus, and she's asking what she should do. So it's a very real thing. Dr. Sullivan in Syracuse, what's your experience been in the ED, and do you have any comments related to this case? Your sound isn't coming through. Let's go back to Dr. Horowitz. After getting this information, do you have any other additional thoughts or, your perspective change with regards to how you'd work with him?
Yeah. So it sounds like we have a trusting relationship. He's followed through well. He's on stable dose of buprenorphine in what I'm gathering to be a good recovery. You're probably going to surprise us later with more complication. But assuming that's the case, I also want to keep him out of the ED. And while I think the ED is safe, there's good reason to, if you can, if he's got a stone, it sounds like at the UBJ, it's small, it's likely to pass, but it's still there. So there's a fair possibility he's going to have another bout of miserable pain. I too would like to maximize anti-inflammatory, but I'm going to be okay giving him a dose or two or a few of an opioid if I have a trusting relationship, if he's in touch with me, and he wasn't before, so I'm troubled by that, to help him get over the hurdle of a stone that is almost surely going to pass. It's small, he's on tamsulosin. If my relationship with him is trusting and in his history supports that this is a safe, reasonable thing to do, I'm okay with it. The likelihood of his using that, if he's on a stable continuous dose of buprenorphine for anything other than pain and to get a meaningful euphoric effect from that, is pretty darn low. So again, I will be open to, depending on him and our relationship, give him a small amount with close contact of opioid to have at home to get over the hurdle.
Hey Tim, this is Ross. Can you hear me now?
Yes, very good. Thank you, Dr. Horowitz. Go ahead.
Yes, Dr. Horowitz, I agree with what everyone has said. I'm a big proponent of maximizing use, and splitting the dose is one consideration. I do often like to increase people's overall daily doses, but what I mean by that is prescribing a few extra 2 milligram films to take throughout the day for pain. And here in Syracuse and in the hospitals, we use that quite a bit for people who don't need to be hospitalized. So, maybe split their dose, 8 milligrams BID, and then throughout the day, if you're starting to feel some type of ureteral or some type of renal, system pain, to maybe take 1 or 2 milligrams sublingually right when he starts to feel that pain, and maybe give somebody, the ability to take 6, or even 8 milligrams a day and divide the doses to help with the pain.
Yeah, those are great comments. In fact, we had a chat from Teresa Baxter, who suggests asking him to split his dose and take half of the film every 6 hours for acute pain, which is in line with what you and others are saying as well. The analgesic effect of buprenorphine is a bit shorter than the duration it keeps people out of withdrawal and effects on cravings. So, and I think the additional doses of buprenorphine are real important. As we'll see later in this case, I make reference to the ASAM opioid use disorder guidelines in the special section on pain, which really changes this year with regards to what to do with patients on buprenorphine. Essentially, keeping the buprenorphine in place is critical, except for almost all of the most severe scenarios where you're just not able to get control of pain, which in my experience doing this in the hospital is very, very uncommon when you leverage the appropriate combinations. And so does anyone have any other suggestions with regards to the treatment of pain in general for patients with buprenorphine, in addition to splitting the doses, adding as needed the non-steroidals any other regarding acute pain? Dr. Weimer, anything else?
I don't think so. I mean, I think I would just reassure him, and like many have said, make sure you have open lines of communication, make sure he's reaching out to you, make, kind of reassurances that you're going to take his pain seriously. I think some of these issues come up when patients feel as though their pain will be, not regarded as serious. So I would just reassure him that you're going to help him get his pain under control.
Very good. Dr. Connor, could you maybe comment on, the anxiety and, this distress people are having about coming out, and you're in a particular, you have a particular perspective with some of the research you're doing now, which we can discuss later, but, what kind of concerns do you have about this patient isolating and being just so anxious at home, potentially?
I don't know if I have a lot to add beyond the discussion so far. I think, connecting with Pantry via telehealth is critical. So any contact like that would, could be really health promoting and reassuring for the patient. Not sure if I have anything more to add about that.
So may I add one to them?
Absolutely. Go ahead.
Yeah, just real quickly, I think it's important when considering how to treat pain is to first step remove the notion of the opioid use disorder and think about the pain phenotype and prognosis. What kind of pain is this? Is it how is it best treated? Is opioid a reasonable part of that? And who is the patient medically? Are they well? Are they engaged? Are they long-lived? Or, in my case as a palliative care doc, are they chronically ill, seriously ill, and dying? That's going to create the range of reasonable approaches. And then to narrow in on what does it mean to, with this setting in which we might consider opioid, what does it mean to have opioid use disorder? What is the recovery relationship? What are your individual risks? So it's tempting to be driven from opioid use disorder as step one. I would, and again, that's probably my perspective in the work I do, I would move that to sort of the second step after considering the range of reasonable possibilities, opioid use disorder notwithstanding.
Yeah, though that is a very good comment. In particular, one of the challenges that sometimes we see is that the question phrased clinically is, patient is on buprenorphine and taking that, and so what in relation to the buprenorphine should we do with the pain treatment? And so buprenorphine can be used for pain in and of itself, and I'm seeing that more frequently, whether it's the off-label use of current formulations for opioid use disorder or some of the specific formulations for pain. And it's increasingly a question within the hospital and even the clinic setting, how does that modify, or does it modify, what I would normally do for the pain in this patient? That's great. Just a second question, and a little bit beyond this patient had some acute pain related to kidney stone. I'm wondering, in a patient maintained on buprenorphine, if you have more time to plan and an upcoming surgery, a total knee or a hip replacement, something more significant, and the patient is taking the same dose of buprenorphine, how might you plan, ahead or guide the treatment perioperatively and postoperatively? Any general suggestions? Dr. Bishevitz?
Splitting. What you might do is talk with the patient about splitting the dose before the surgery is scheduled, and also increase the dose before the surgery is maybe have a patient go up the day before and plan on increasing the dose like we discussed for this purpose of the surgery, but also talk to the surgeon about using a shorter acting opiate on top of the buprenorphine would be okay, because a lot of people don't know that or just want that guidance.
Very good, right? And anticipate working with the patients and planning and also presenting. Because you're on buprenorphine, that doesn't mean we can't treat your pain. In fact, it allows us some specific opportunities, I think, is really useful in preparing them. Let's advance to the next slide. The patient, after having a good discussion and deciding that he wouldn't pick up the morphine, he was going to work with the NSAIDs and Telemedicine, calls the next day and he's irritable and complains of pain. He reports he hasn't passed a stone and his friends are getting him worked up about the pain, and the pain is back. He hadn't returned to the ED. The urologist's office is closed to contact that afternoon, but left a message about a follow-up CT scan scheduled in a few weeks. He reports he's taking both the buprenorphine and he's splitting it and crushing up 3 ibuprofen every few hours and drinking it water. He denies any use of opiates or other drugs except the Telemedicine. The provider at this point wants to bring him in to do a brief on-site visit and urine screen, but the patient is hesitant due to COVID, but was out running errands when he called. So I'm wondering how are providers meeting patients on site in clinics during the coronavirus? How often is urine drug screening being done in these situations, and what would you do in this case? And this is an outpatient chemical dependency treatment program. Dr. Sullivan, what would you do here?
Well, this is a lot like what we're doing now. We have been really using telemedicine, and this is somebody that I would really love to actually see with telemedicine and video face to face. Talk to them. First being to talk to them about their actual urologic pain. Is this someone who does have to go to the ED? Are they having decreased urine output? Are they having fevers? And that's the first thing. Second thing is we're really doing almost no urine drug screens. And for our walk-ins brand new who may need some like outpatient detox, maybe they're going to get some to maybe help guide care. But for the most part, we're meeting our patients over video or phone. This person, I would not even think about doing a urine drug screen. But I, again, would talk to them and consider if they don't need to go back to the hospital, again, increasing the patient's buprenorphine and trying to handle their pain. I do know that you can add full opioid agonist on as well. I just tend to try to shy away from that and use it, if the additional doses of buprenorphine don't help.
Okay, very good. Dr. Bashevitz, at the opiate treatment program, you're certainly bringing patients in for the dispensing methadone, but are you bringing any of the buprenorphine patients in when you see signs that they're struggling, or for testing in critical cases?
Well, yes, we might bring them in if they are struggling, or if we need to see a urine screen. But most of the time, we're not bringing them in. We're doing the telemedicine visits as well. Very good. And we've started to bring more patients in with a very controlled process, screening fever, symptoms, masks, gloves, one at a time. I've seen too many patients supposed to be taking buprenorphine overdose in the hospital, including fatal overdoses at longer bridge prescriptions. And I think whether or not it's a combination of factors, I'm sure in every case, but for some of the patients we've struggled with that have red flags, aren't able to do an observed dose via audio video connection, or have some red flags. This is somebody I'd want to bring in and see how he's doing. And we do maybe 1 or 2 urine screens a day, but it'd be useful to me. It's also doing some odd things like crushing up the ibuprofen and putting it in water. And so this is, some of the behaviors are just different than the stability from the last 18 months. The morphine is apparently still at the pharmacy for the patient. Prescription monitoring program only shows the buprenorphine naloxone dispensement at this point, although there could be a lag. He does deny picking it up. Let's go to the next slide. Patient, after initially refusing, does agree to come in for a screen.
misses the first time and isn't answering his phone and is kind of missing for 2 days, but then calls and reports he's able to come in now. When he does, he's well appearing and pleasant, and he says the pain hasn't returned. He got through it with extra Suboxone, but not too much extra. He took 1 or 2 extra strips. He has a follow-up with the urologist 1 to 2 weeks, and his urine screen, which was done that day, returns a few days later. Next slide. With negative analytes except for opiates. And this is 7 days after he had been in the emergency department. Next slide. His morphine level is pretty low. His norbuprenorphine to creatinine ratio is good. So he's clearly taking his buprenorphine. And he has very low levels of morphine, consistent with getting some in the emergency department. It's a little far out, up to 7 days, but perhaps a small amount might be left. It could also represent, a small amount of heroin, but he appeared well and had been taking his buprenorphine. So, we just attributed it to that. Does anybody have any last comments regarding the screen or any other aspects to this case? Dr. Horowitz, any other pearls?
No, not really. The morphine made me groan a little bit though, because it is a week out. You got 1 dose of morphine that didn't affect him in the hydromorphone. So I don't know. This makes me a little, a little unhappy. I just wondering. I wish that said negative, Tim. Come on.
I wish it said negative too, but so this instead of a monthly follow-up would be moved to a weekly and bring him in. And yeah, I think it's 7 days and from a 2 to 4 milligram dose of morphine, it probably should be out of his urine. That's uncommon to still have. He denied picking up the morphine. We confirmed with the pharmacy, but yeah, it is a stretch. And most of the heroin in our area is going to be fentanyl, so there was no fentanyl in his urine, but this could represent codeine, morphine, a little heroin. But most importantly, he's taking the buprenorphine, and I think waiting 2 days was also a little bit of a red flag.
Yeah, agreed.
Jim, this is Ingrid Vikas. I'm just wondering what the rationale was for calling you back for your what the sub it was and what.
You're breaking up a little.
Oh, sorry.
Louder,
I'm just wondering what the rationale was for doing a UBS. I know we've essentially stopped doing UBSs, like some of the other speakers or panelists have indicated. So, can you share what the rationale was and what your plan was in terms of what to do with it once you got it back?
Oh, absolutely. Yeah. I mean, I think it's very useful in many patients for confirming they're taking the medication, as well as accountability. And I've had patients call specifically asking to come in to do screens in situations. One situation was a woman had a CPS case that was recent, and she wanted to come in so that she had track record. She was worried that she was not showing that she was remaining sober during that time frame. And I also felt we can safely bring in appropriate patients with the right protocols in an outpatient setting when you're consistent and follow the right protocols. I've had fatalities when patients have been prescribed opiates perioperatively or in similar situations that I thought they were stable, and they took themselves off the buprenorphine, and that triggered a full relapse and ultimately an overdose. And so I consider, the urine screen, while we're doing minimal, we're probably doing 1%, if that, of the screens that we had historically done. I think for some patients, the face-to-face interaction, when you can do it safely, and that was more important really than really getting the urine screen. And the urine screen to confirm that he's still taking the buprenorphine, that this pain episode didn't trigger, craving relapse and extremely low levels of buprenorphine here, and fentanyl opiates would have triggered a callback discussion and offer to get him into one of the local detoxes potentially to stabilize. So, I think in reduced frequency right now, definitely, but there are scenarios where it can be really critical and very useful, and I thought this was one. certainly, there's a variety of different practices, and also probably the presence of COVID. How high is it in the community? If this was downstate in late March, we wouldn't have brought him in to do a urine screen. We would have just simply, had the audio-video connection. So let's move on to the next case. We've got a couple of other really good cases. Next slide. Historically, go back one slide. This is historically his pattern. It covers actually years before coming in with the previous program when heroin was truly heroin in our area, and you could see he had in the years before entering detox, morphine along with other analytes, and then in the screens negative, and then he just has a very small level of morphine. But next slide. Let's move on to case number 2. And I want to reference the ASAM National Practice Guideline for the treatment of opioid use disorder section on acute pain management. There's part 9, pages 54 to 56, some excellent information, much of what we discussed on this during this case. Next slide. And I have an algorithm for the treatment of pain, and certainly, as Dr. Horowitz mentioned, there's a lot of other factors to consider in removing the opioid use disorder and approaching it as to pain phenotype is critical as well. These slides will be available as the recording. Next slide. Some references related to pain and opioid use disorder. Next slide. Case 2 involves a 60-year-old female who under normal circumstances receives 2 weeks prescription, but since the COVID-19 pandemic has received 30 days to minimize travel and contact with pharmacy, she calls 8 days early, reporting she is out. Next slide. The patient normally takes 8 milligrams of the mono product, buprenorphine alone, 3 times a day. She started on this in an area inpatient program and was transitioned to the outpatient program due to nausea and allergies with the naloxone 1. She has vague reasons as to why she took the extra doses: tooth pain, joint pain, arthritis. She has 2 urine screens from prior to on-site service being limited, which are positive for buprenorphine metabolites, THC and diazepam metabolites, which was from a protocol medication from the treatment program. She'd only had phone encounters since on-site services stopped. She has no smartphone or computer. She has a history of heroin, fentanyl, cocaine, THC, and intermittent benzodiazepine, as well as gabapentin abuse. She has unstable housing. She's either staying with a family or a significant other, both with history of substance use, and we have limited information about this. Has erratic contact initially and throughout, but did have contact with the program both pre and post coronavirus. And she's asking to fill the prescription early or she will return to heroin use. It is 8 days early. So what do you do? Dr. Bashevitz, can you comment on what you would do with this patient?
Is not to give. My bias is not to give her a new prescription because most of the time it's either been overused or sold or something like that. So I would talk with her about why she had been overusing it, what reasons she had been overusing it for, and that kind of thing. Sometimes when people have just started a buprenorphine program, they are unclear about the rules, and normally what we try and do is get them to sign a rules contract up front about that. Many people are used to taking medicines like this PRN, and you have to get them around to the idea that it's not exactly a PRN. It is something that should take as directed. So that's one consideration. I would offer her something like clonidine until the pharmacy was able to fill her next prescription. The other issue, of course, is that she's already at a maximum dose of buprenorphine, 24 milligrams. Most insurances won't pay for more than that, and the pharmacy won't fill it early, usually, because insurance won't pay for it. So, sometimes if we're 100% sure that people got it stolen or something like that, pharmacies can be convinced to let them pay cash for a little bit more. it depends on your area and on the pharmacist's point of view as well. And then, of course, we can consider also a higher level of care for her because something appears to be going on.
Right. Excellent. Yeah, all of those things are considered. I think, we're in a particularly difficult time. One of the local pharmacies early on was doing deliveries, and I know a large part of their clientele had addresses that listed the last detox or were in large apartment complexes that really didn't have appropriate places to drop medications. And there's a lot of patients that, had lost, missing, or non-delivered prescriptions. And, it's really required some, nuanced thinking and perspective and certainly early on, much more harm reduction approach and just getting buprenorphine out there. But I think a lot of the pharmacy delivery and other factors have been ironed out, at least in many areas. Dr. Horowitz, I'm wondering, your population pain and palliative care, are you seeing both taking extra medications during the emergency due to anxiety, or have you seen an uptick of cases where people are running out early, or what's your perspective?
Yeah, no, I haven't seen that. I actually, my last situation like this, Tim, you helped hold my hand through, but it was a story very similar to this, and it ended up that that gentleman was not using the buprenorphine. He was using a little bit of it, but most of it he was using in business transactions, we might say. And this also may well be a sincere misunderstanding on her part. There's some red flags here that make me a little bit nervous, and she's one I would certainly wonder about what her urine screen would show, really, to make sure I'm doing right by her, by me, by the community.
Yeah, those are great comments. One of the things about bringing someone in on site is we also have a food pantry associated with the outpatient Huther Helping Hands, and so are able to give people groceries and some other things. And so in addition to just bringing in and doing a quick connection, there's some other incentive. And, this is a patient that we would definitely bring in. Let's move to the next slide. Next, there we go. She's relatively new to this outpatient clinic, having only been attending a few weeks prior to the COVID interruption. But there's a long history of the opioid and substance use, and she's had a variety of different treatment programs and providers. In fact, we can see on the prescription monitoring program 11 different prescribers of buprenorphine, mostly very short durations of prescriptions. There are a couple of longer prescriptions with what appear to be very rapid detox protocol prescriptions. For example, one for 84 buprenorphine and TID dosing for 28 days, and then within 1 to 2 weeks after, there's the protocol meds from an area detox indicating that diversion or what have you as a buprenorphine commodity broker, essentially. And so this is not a case where we would simply prescribe extra medication, and potentially discuss Sublocade, the long-acting injectable, which is another reason we've brought patients in to continue the long-acting injectable prescriptions. Next slide. Patient initially states that she is not going to come in to get testing and meet with provider, nor does she want to go to the detox. But on the next day, she calls up stating she's on the way in. The groceries from the pantry were offered, and she requested these be ready. We've already talked a little bit about how frequently urine screens are being done, so I'm not going to readdress that. On-site dip and send-outs could be done. Mostly we don't do the on-site dip, just kind of minimizing the protocol and the contacts. So, our process has certainly changed. And, the next part of this is we look towards opening potentially. This varies state by state, but I'm wondering how do people see the drug testing changing, evolving as the summer, fall pandemic evolves and cases drop? What are your perspectives, Dr. Sullivan?
Yes, thank you. I think this is a really interesting question because, it seems like we're shaking forward, 2 steps forward, 1 step backwards. I kind of foresee into the early part of the summer, I would think that drug testing is going to be pretty similar to the way it is now. I can see it for most of the summer. If it does increase, it's going to be, because right now it's for a patient who they think are in imminent danger, or if there's an imminent emergent reason to do so. That's kind of the state in OASAS's guidance, which makes sense for now. But I think cases like this do almost fall into that category. And cases like this, I think you should be able to be tested as the summer goes on. I would think that patients like this are maybe not in emergent danger, but still in some type of danger, will probably need to be tested in some capacity. What we would do here is we would probably either, if they're coming in to get something else, due to COVID, we would probably do what we have been doing, our unwitnessed urines, or oral swabbing, very easy to do with social distancing. So we would probably, this patient here does seem like could be at danger, or not, or could be diverting. But either way, I think a urine drug screen or something may be in order for this patient, as we want to make sure we're doing things safely.
Yeah, that's an interesting comment about the oral swabs. There's all sorts of guidance coming out, and some of the drug testing certainly isn't related to clinical addiction medicine. There's the professional athletes and protocols where they have year-round screening. I've seen protocol developments for an at-home video witness process. It'll be very interesting to see how that plays out in other areas as well. Dr. Weimer, do you want to comment on testing or any other comments about this case?
Yes, thank you. I don't have a lot to add about urine drug testing. I guess my primary priority for this patient would be to ensure that she's safe. And it sounds like there are some signals here showing us that she may not be safe and she may be at high risk for overdose. So something we didn't mention, but I think is really important to address is discussing harm reduction options with her, making sure she has naloxone. If she is continuing to use, making sure that she has adequate access to safe injection supplies. That is something that has been compromised with COVID-19, and many of my patients have had to reuse needles that they would not have other used given the lack of access. So those are some issues that I would be thinking about. Also talking to her about, if she is homeless and is staying on the street, making sure she has access to adequate hygiene, ways to wash her hands. I mean, these are really basic things that many of our patients are struggling with and are important, not just to keep them from opioid overdose, but also to keep them safe from contracting COVID.
Yeah, great comment. Unfortunately, most of the ways that we would, try and work with this patient really have been limited, but not all. Having our peers make phone calls with her, trying to find creative ways that maybe she can get some access to the internet through phone calls. We would normally send a peer out to meet with her. The groceries, I think, from the pantry were quite useful. And looking at the risk-benefit of bringing this patient in, there's an awful lot to gain when done safely compared to just simply having phone contact and continuing to prescribe when there's no knowledge about really what's going on. There's a lot of risk here. So those are great comments, Dr. Weimer. Now, let's move on to the next slide. The patient is surprised we actually do a dip. I want to find out what is being taken on site. I think it's the only dip that I've done in the last 6 weeks, 8 weeks. And it comes back positive for oxycodone, THC, methadone, benzodiazepines, cocaine, and buprenorphine. And 3 weeks ago, there was only buprenorphine, diazepam, and THC. She doesn't have any more buprenorphine. How do you proceed? And for the sake of brevity, I'm just going to comment on how we proceeded. She was offered referral to a detox bed as well as a follow-up call the next day, and she was going to mull that over. Next slide. And went to efforts to facilitate the admission at the detox, which she declines. She is not in withdrawal at the in-person visit. She confirms she's not able to arrange video conferencing, doesn't want to come in to do another drug test with COVID around, and ultimately she leaves with the open offer to get help into detox, but not with a new prescription. The confirmation labs return with really low levels of buprenorphine, essentially not existent, methadone, alprazolam, diazepam, gabapentin, oxycodone, THC. And this is a very challenging patient that the telehealth and even during ideal operations is challenge and at very high risk for overdose. I'm not going to end the conversation, I think, about this case. We'll move on to case 3, which involves a different sort of topic, but there's certainly a lot of interesting nuances that come to light, both challenges when working with resources that have been offered to us, the telephone, the telehealth, but limitations in all settings. Next slide. So case 3 is a little bit different. It's a 22-year-old female with alcohol use disorder who has increased her drinking since the COVID-19 pandemic, and she reaches out for help. Next slide. Patient has increased her drinking since a stay-at-home order went out. She starts in the morning, unless her kids are with me, and then continues until blacking out, usually in the evening. She has 2 young kids that are in with her half-time, and being sober around them is her main reason for reaching out to help and motivation to stop. And she says, bad things have happened when I blacked out. Patient is adamant about not entering the detox facilities due to COVID-19 and childcare. She wants to be available for childcare. Other than THC, she denies use of other substances. All visits to this point have been via phone and 1 direct audio-video medical screen. She is interested in getting help while she is at home for the withdrawals and shakes and my anxiety. No history of seizures or history of delirium hallucinations, only 1 hospital visit prior. About a year ago, she had intoxication and was suicidal, didn't have an actual attempt, just was intoxicated and suicidal, and she was cleared very quickly from the emergency psychiatry and sent home and didn't follow up. Next slide. In New York, liquor stores were considered essential services and remained open during the emergency stay-at-home orders, and food delivery could also include liquor and alcohol. In other states, Pennsylvania, the state-run stores closed. So my question for Dr. Connor to start is, what are the pros and cons of the different ways the states have chosen to manage alcohol sales during the COVID emergency? And what have you seen in New York as this has progressed related to alcohol consumption? Dr. Connor.
Can you hear me?
Yes.
Yeah. I'm, as you know, I'm running a clinical trial with patients who are out of treatment with alcoholism. They're residing in the community, and we reassess their alcohol consumption regularly. So I don't know if we have a handle on the pattern yet about changes since, the COVID-19 crisis emerged. I mean, there's some cases I can think of, people who are not working anymore and have little to do to structure their time and are drinking during the day in ways that they weren't before. The most helpful thing that I've found for trying to get a handle on withdrawal risk over the phone with patients is we use a technique called timeline follow back, where we essentially understand people's drinking over the past 30 days on a day-to-day basis. And that can be enormously instructive for trying to get some sense for risk associated with withdrawal. The other thing that is really helpful is to assess alcohol withdrawal itself. And particularly, it's helpful to me to look for episodes of delirium or seizures in the past in thinking about risk with patients. The liquor store thing, I mean, I'm not sure what to say about that. I think that, the idea was that they didn't want patients coming or patients going into withdrawal or people going into withdrawal because they couldn't access alcohol. So they didn't want to just cut off the supply abruptly. And you can appreciate why that would be, because people could be at risk at home in their community, et cetera. So I think that was the mindset before around making available or alcohol available. So.
Very good. One other thing to consider was the detox in inpatient beds had been reduced early on, in particular in our area, and I know downstate, as many hospital-based detox units had the beds used for coronavirus cases, and so the availability to even enter detox was reduced, as well as the burden in the ED, and so keeping it open. Although from some estimates, consumption of liquor is up close to 50% higher, and maybe even more in New York and in other areas. Just the amount of alcohol consumption is dramatically increased. So, I've been sent letters and surveys that request signature to mend the essential services for ask the government to amend the essential services, and there's certainly pros and cons of having the alcohol available, but I think when prohibition has taught us some lessons that bad stuff happen when we restrict access, but it is certainly a very nuanced debate with both pros and cons of having the alcohol available in the setting such as we have. So let's move on. Next slide. The patient has been drinking heavily for about a year prior to that, binge drinking, but not daily. Her current significant other is a daily drinker and drinks with that at the end of the day and going to bed, not during the day. He's still working during the emergency, some construction work. The COVID emergency and isolation led to dramatically more alcohol use for her. She has no recent hospitalizations. I mentioned the psychiatric visit while drinking. She's not taking any medications, no primary care. She smokes some Black and Tans, 2 to 3 a day, but not a full one each time, about $10 of cannabis every other day. And the alcohol use is 4 to 5 24-ounce beers, an occasional pint of Hennessy or other liquor, and some shots. A little bit less of kids, concentrated a little bit more when kids are there after dinner and bed. Next slide. I just wanted to comment on screening for appropriate patients. Ambulatory detox is a way of managing withdrawal in the outpatient setting. And I'm wondering, Dr. Weimer, you have a lot of experience with ambulatory detox, and how does the COVID practice changes change what we would normally do for ambulatory detoxification screening and patient selection?
I think we still utilize the same approach where patients who have high risk of having a complication related to their possible alcohol withdrawal, such as, age greater than 65, history of DTs, history of seizure, things like that, we still recommend inpatient alcohol withdrawal management. I think with the new ASAM alcohol withdrawal guideline, which does provide some more guidance around how to select patients carefully for outpatient-based withdrawal protocols, that is something that perhaps we can utilize more, particularly in this situation. Though I do have to say that when I've been seeing patients recently coming in for alcohol withdrawal, I've personally noticed that many of them are drinking much more than they were before. So that worries me a bit about only doing ambulatory withdrawal protocols. So I think you can do it. You just have to be very careful about who's an appropriate candidate.
Yeah, those are great comments. I just want to let the panelists know we're going to be going on for about 5 to 10 more minutes beyond the 1 o'clock, or beyond the 2 o'clock. So just an FYI if you need to drop off. But it's certainly the acceptability of risk really depends on your geographic region, the presence of bed availability in the hospital detox setting, your familiarity with ambulatory detox, the patient's setting, if there really are no other options, and the patient only other option is to have untreated withdrawal, you may accept a patient that you normally wouldn't in the time of COVID. Dr. Sullivan, do you have much experience with ambulatory detox, and what kind of criteria would you use to select patients now?
Yeah, I've used this prediction of alcohol withdrawal severity scale a few times, especially for people who don't have some people can tell you pretty accurately what they go through, and this patient, not really. There's so many factors that go into it. One going against this patient is that she lives with someone else who drinks pretty heavily. But when I have done these, I try to have regular check-ins. Maybe with telemedicine, it almost makes it easier. So these are things where I would, if the patient really seems really hell-bent and really wants to do this, this is something I would do, but I would do it with trying to have daily, telemedicine visits with myself or, one of my associates to kind of assess their withdrawal. Also noting that you would need some benzodiazepine, you would think very early on, but weighing the risks of, not prescribing too many at one time with someone who has a propensity to drink a lot. So, there's a lot to really think about for a patient like this, but I have done them in the past, and in full disclosure, a lot of times they end up going to detox because it ends up being pretty difficult for them to achieve.
Yeah, that's very good. Good comments, and I think in particular, about benzodiazepines, and it also is important whether or not they have an opioid use disorder or there are other substances involved as well. And Dr. Bashevitz, do you ambulatory detox options through Strong Recovery or perspective on patient selection currently?
So we do the ambulatory detox mostly for opiates right now, but this is a case that represents, it's very similar to other patients that I've done ambulatory detox with. And I think when we're not in a pandemic and opportunities for person-to-person interaction are less limited, my preference in the past was to actually meet the family member who would be helping with administering the benzodiazepine. But in this case, it wouldn't happen most likely. The other concern, of course, beyond what the other folks had said, is sometimes you get a family member who is likely to maybe take the benzodiazepines himself or take them and sell them or something like that. And that's a dangerous situation too, of course. So you'd like to get some better idea of the person, maybe at least talk to him on the phone and that kind of thing. Figure out if you think he's reasonable.
Yeah, those are good comments. And in this case in particular, that wasn't an option. The other partner was either working, and candidly, she didn't think he would stop drinking, but she wanted to get help. We discussed a protocol after interviewing her fully, and that to do this, she needed to be willing to check in daily via phone as well as an audio video session at least once, or if I had concern, and that we would have a single in-person visit the first week, and then it would depend on how she was doing, how our encounters had been going. But she was enthusiastic about at least having the supports, and was able to describe the process after we'd be reviewed and expectations. But the only encounters that I'd had before starting with this patient had really been just through phone and in the single audio video. I have the prediction of alcohol withdrawal severity scale as one of the screening options really used for hospitalized patients for complicated alcohol withdrawal. And I think, in somebody that screened high with this score, I would be much more leery and look for opportunities to potentially get them inpatient. And next slide. This score and calculation available through MedCalc as a series of questions. Basically, if you have a threshold criteria of any alcohol consumption within the last 30 days or blood alcohol level over 200 in the ED or hospital, you would progress. If not, it wouldn't complete the score. And then there's a series of questions related to markers of alcohol severity or alcohol use disorder severity. Have you been intoxicated or drunk in the last 30 days? Blackouts, seizures, used alcohol with other substances, sedatives, any other drugs in general. Next slide. And basically a score of 4 or above indicates a very high risk for more complicated withdrawal. And our patient scored 3, so she was a little bit lower risk, and we elected to proceed with the ambulatory detox. Next slide. That wasn't the pause, is certainly not the only information we relied on to decide. So in trying to determine what medications you'd use for this patient, we had some comments of benzodiazepines. What are typical ambulatory detoxification medications that you've used in your practice or you've seen used? Dr. Weimer, you mentioned the ASAM guidelines. Can you comment a little bit on what they recommend or what you might use?
Typically for alcohol withdrawal, we utilize a benzodiazepine, and we may use adjuvant medications along with that. And the ASAM clinical guideline goes through some of those various medications, such as hydroxyzine, thiamine, folate, of course, for vitamin replacement. And then the guideline does go through utilizing phenobarbital. I don't personally use that in my practice unless patients are in the ICU, though I'm interested to hear what other panelists like Dr. Sullivan and you, how you're utilizing that medication.
Yeah, great. Thank you. It's interesting in the outpatient setting and ambulatory detox without opioid use disorder, I really favor gabapentin and maybe a little bit of benzodiazepine and adjunctive clonidine, as well as the supportive nutrition, thiamine, multivitamin. And I find that if you start early before the withdrawal onset, the gabapentin is very effective and can also be transitioned into an anti-craving medication. Dr. Sullivan, do you have thoughts on protocols or what's your experience?
Those are, Tim, that's pretty much exactly what I do in the outpatient. Or for these ambulatory cases, I tend to start gabapentin, relatively low as I use benzodiazepines for the first few days as there's, maybe an appreciable CELA score. And then with a self-tapering benzo like, Valium, you can stop that without worrying about having to taper that, and you can start slowly increasing the gabapentin. And then adjuncts like clonidine, I do use hydroxyzine as well sometimes, but that's pretty much my regimen, as well as all the supplements you mentioned.
Thank you. Dr. Vikas, do you have any comments on ambulatory detox?
No, not beyond what people have mentioned. I don't deal a lot with alcohol withdrawal in the outpatient scenario, so I have nothing more to add.
Thank you. It's interesting. In some states, for California, for example, Medi-Cal does not cover detox setting. They may cover the more severe withdrawal treatment in a hospital, but detox units are not options. And so some clinicians have, ambulatory detox as a regular component of their practice if they're working with alcohol withdrawal frequently. Next slide. So the patient is prescribed 600 milligrams of gabapentin to take every 6 hours before she starts to feel any withdrawal. She's given clonidine 0.1 4 times a day as needed for anxiety after taking the gabapentin, 20 tabs. 20 tabs of each were given as a first prescription, and 2 5-milligram tabs of diazepam were given for her the first night to take if she goes to sleep, hasn't been drinking, and she goes to sleep and is not able to sleep despite the gabapentin and clonidine. She's also on a multivitamin, thiamine, encouraged to maintain hydration and drink juice, fluids, and follow his schedule. Next slide. Audio-video visits are set up for the first contact, which she states she's doing fine. She says, I'm a little tired, but not having any shakes. She reports setting my watch by the hour to make sure I don't miss any doses. She did not take the diazepam and is using 1 or 2 of the clonidine tabs daily. She's taking the gabapentin regularly. And on the video call, she appears fine, but she's somewhat depressed. She says, my kids aren't here, and this is when it's hard. Counselor and peer counselor given her info, and she's given info on internet AA and women's groups and other resources to check into. She's somewhat isolated during the day. On day 2, a phone, she confirms no alcohol use, sounds okay, no slurred speech, no use of diazepam, no withdrawal. On day 3, which is only phone, same as day 2, taking meds, 1 to 2 clonidine a day. Gabapentin is making her hungry. And day 4 is an in-person visit where she's anxious but relaxes during the visit. Urine screen is done, and she admits to 1 or 2 drinks, just small beers 2 days prior, but nothing like what I was doing. And it's at this point that naltrexone is ordered with instructions to start 1/2 of it, and then the next day take 50 milligrams a day, and continue with the gabapentin, which is changed to 600 milligrams 3 times a day after the 5th day. She still hasn't taken any diazepam. Next slide. On day 6, she switched after the 5th day to the 600 PO/TID of the gabapentin, and she's now taking naltrexone. An SSRI is started in the 2nd week based on her report of depressive symptoms and ongoing interview. And at the end of week 2, she reports maybe a beer or 2 once this week, and she isn't noticing the gabapentin or naltrexone, just taking them. And she comments that she's attended several internet AA meetings and enjoys participating or listening, as well as a women's group mutual self-help meeting. And their urine screen returns from her in-person visit. Next slide. Show THC, a small amount of THC. She had not changed the pattern of THC use during this. Specimen is valid. Next slide. And her biomarkers for alcohol were negative. The ethyl glucuronide and ethyl sulfate were negative. Next slide. And the gabapentin was positive. We are able to test for gabapentin, so I really interpreted this is her urine. She's doing good, and I was very impressed. And I told her that it's a process that 1 to 2 drinks is much better than what she'd been doing, and she's off to a great start. She continues with weekly check-in with the physician, the counselor, and seems to be doing well on the medication regimen, is referred to primary care. And in general, are there any other comments related to degrees of risk and risk benefits of being able to provide ambulatory detox support, and what degrees of risk do you tolerate for patients with limited contact and minimal on-site testing? We've already kind of discussed this, but does anybody have any closing comments or suggestions? Connor.
Nice to end with such a successful case. Nothing to add.
Dr. Bishevitz?
I would just add one comment, which I've always tried to do. If there is a chance of picking which day of the week you're going to start the detox on, I start that on Monday or Tuesday, so that we don't run too much into the weekend if the patient is having trouble, and we have enough time to refer her to a higher level of care and so forth. That's very helpful process-wise.
Yeah, that's great. And that's essentially the visit with the testing was before the weekend. Dr. Sullivan, any other further comments, Pearls?
No, just for these cases in general, whether it's with COVID-19 or not, I don't know. I think you really have to keep a nice, close, watch, like everyone said, on these people, just to make sure they're safe and, assess risk, just like you did in this case. A few drinks is better than, 15 to 20. And this is a great case and shows us that it can be done. So this is a very good one.
Thank you. Dr. Vikas, any other comments?
Oh, thanks for sharing this success story where we always need to be glad when there are success stories. I think also the patients need to, in terms of triaging, she was really very motivated. It might have been a very different outcome or approach with someone not so motivated.
Right, very, very, very true. Move on to the next slide. We've referenced the ASAM clinical practice guideline on alcohol withdrawal management, and there is sections on all levels of care, but the ambulatory management section is particularly pertinent given the COVID emergency. Next slide. The patient continues to do well now 4 weeks in, planning to schedule another in-person visit. Not going to discuss really the preparing the in-person visits at the office sites for patients. We mentioned a little bit having a protocol, PPE, screening, and that really is important that staff are educated and you really follow appropriate process. Next slide. We are really at the end for any Q&A. Next slide. Just want to announce an upcoming event, the ACMT and Partners COVID-19 webinar series, Mitigating the Intersection of COVID-19 and Opioid Use Disorder, is this Wednesday, May 20th at 3 p.m. Eastern Time, and you can see the embedded link for the ACMT and Partners event. And I want to thank both American College of Medical Toxicology and the American Society of Addiction Medicine for collaborating. Both sites and both professional organizations, websites and the professional organizations have excellent resources and e-learning libraries related to the coronavirus. And I encourage attendees to check out the COVID support through ASAM, as well as the COVID support webinar series through ACMT. Next slide. I think that is it. We are at the end. I want to thank our panelists and our support and attendees. The presentations are recorded and will be available, and please fill out the comments and questionnaire for CME, as well as just simply comments on future topics and presentation. Thank you all for joining, and be safe and have a great weekend. Thank you.